Heart attacks come from the inside out. If you don't see the wall, you miss the threat. At least 2 studies showed either a 50 or 70% of the first-time heart attacks occurred with people that had normal cholesterol and no symptoms, or at least no typical symptoms.
Which is scary, right? In my practice, I constantly have patients come in and say to me, the reason I had a heart attack is because I had a major blockage. Is that the only reason? Is that the major reason people have heart attacks?
Absolutely not.
What else can cause it?
So what if I told you that the majority of heart attacks that might kill you are from small little blockages? That's actually the truth. I often have a pop quiz when new patients come in. I say, okay, 30, 60, and 80% blockage. Part 1, which one do you think will be more fatal? And then they usually answer
the big one.
The big one.
Yeah.
And then I say, all right, part 2, 30, 60, 80. Which one do you think will give you chest pain? Which one's going to give you shortness of breath, going to make you feel lousy? And they go, well, 80. And I go, everybody fails the first part. Yeah. So we've known actually for decades, or at least science has known and shown for decades, that most fatal heart attacks occur from small blockages. So, I mean, you think about it, there's 2 analogies I use. Think about traffic on the parkway. At least by us, and especially in the summer. You can have a lot of congestion,
right.
Okay? And it slows the traffic down, but it's still flowing, okay? But what if there's a pothole and a tire blowout and causes a major accident? That's a heart attack, okay? Just a small little pothole in the road caused potential fatal accident, or in this case, a fatal heart attack. Yeah. How about another way to look at it? You have a drain in a sink, okay? Over time, because you yell at me all the time, the hair gets in the sink and the drain starts backing up, right. Okay? But it's still flowing, all right? And
that's what you always say.
And then we call the plumber, and then he unclogs it. But that's not the major problem. It's what if there was a small little area on the pipe a little bubble, okay, that continues to grow a little bit and then pops, okay? In the body, okay, that's what we call a ruptured plaque, and a clot is made to kind of seal that crack up.
Right.
And that clot is a heart attack, okay? So that's why everybody fails the first part. And as I said, we've known for decades this action. So that's what we're here to talk about today. How we get it, why we get it,
and how not to get it.
And how not to get it.
Got it.
And then there's a couple causes that lead us into that crack in the foundation, the crack in the pipe, right. Or the pothole. And you deal with it in nutrition all the time.
I do.
And that leads to all the problems that occur.
We know that inflammation, which we talk about a lot, insulin resistance, right? The body's inability. Prediabetes, or the body's inability to react to insulin. Oxidative stress is a huge one, and that So what is oxidative stress? So this is my little analogy that I try and use with my patients. So bear with me because it's a Phil created analogy, but your body is a busy city, and the cells are the workers, and where they're making energy. And when they make that energy, they leave behind sparks. And those sparks are what we call free radicals in the body. And then we eat really healthy food, so the body uses antioxidants or firefighters to put out those sparks in the body. But when we have too many sparks and not enough firefighters, there's a lot of damage, and it could damage your building, right? And that's oxidative stress. It's like cell rust in the body, and it creates a lot of damage internally. And so what we want to do is really, and from a nutritional standpoint, and what we have a lot of control over, right? When we say certain disease states or certain things are preventable, you are born who you're born to.
You are born.
Your genetics.
I was going to say, look, there's a certain amount of genetics that are in fact, and I specialize in that, so it's what we look at every single day. And yes, so that we can be born to have a lot of oxidative stress, and we get plaque in our arteries, and we also can cause all of that oxidative stress by our lifestyle.
We can, but the things that we can control and help to do or to reduce is our diet, right? Which is following an anti-inflammatory diet, which we will talk a little bit about in this episode, but we will continuously talk about that. How much sleep we get, stress and stress management.
We go back to our first episode.
Right.
We talked about those
stress,
exercises.
What does it do to your body? Movement, just getting and doing some movement, right?
Yep.
Whether it's organized activity or just walking every single day. No smoking, right? Smoking is a huge factor in creating
Oxidation.
inflammation and oxidative and free radicals,
Yep.
those things we talked
Yep.
about, and alcohol consumption.
Yeah.
So I like a good cocktail too. However, we really have to be mindful of how much alcohol and how much is safe, because alcohol is incredibly inflammatory.
Well, as they say now, there's no amount that's good, but we'll.
And I think one thing that's no fun. Like
Right.
we're never really bringing good news, all right? Like
That's
you
the
can't
newest.
eat
Is
bad,
there's
you
no
can't
amount
drink
that's
bad.
good for you. It used to be, a glass of wine every day.
Yeah. Well, we'll talk about it. But there's one more thing that's really, really important. Your toxin load, your toxin or toxic load of your
Yeah,
body.
yeah.
Your skin is your largest organ. And I think people forget that what we put in our mouth is incredibly important. But we put on our body, on our hair, on our skin.
All of it.
If it's toxic to your body, it creates a tremendous amount of inflammation. And so those are all the factors that we have
Yeah.
to think about on a daily basis.
Yeah. So let's talk science, all right? I always like to give you a couple studies that you could take home with. In 2004, and again, science actually showed back in the early 90s about this issue about 30, 60, and 80% blockages. But in 2004, it was a kind of the changing of the guard, and as from those of us that practice cholesterol medicine, because we understood about stabilizing a plaque that's unstable, what we call a vulnerable plaque. Not just regressing it or shrinking it, which is kind of prior to that point. It showed that stabilizing reduces those heart attacks, keeps the tire from being blown in a pothole, so to speak. In 2011, moving forward 7 years, they showed that minor plaques on an angiogram, catheterizations that I perform, where we shoot a little dye and we take pictures of the arteries, either by the wrist or by the groin. Minor plaques, it was one of the first times they showed, had a 64% increase in heart attacks on follow-up, a specific specified follow-up. And just more recently, in 2017, at least 2 studies showed either a 50 or 70% of the first-time heart attacks occurred with people that had normal cholesterol and no symptoms, or at least no typical
Which is
symptoms.
scary, right? Because people think, oh,
That's the heart attack you never see coming.
Right. My cholesterol is fine. I can eat what I want. I can do what I want. I can drink what I want. But you're saying that's not at all the case.
Not at all. I was recently happily part of a case of a 35-year-old kid in fantastic shape, terrible family history, exercises locally at a gym, and was at the gym and had cardiac arrest. Placed on a ventilator, initially not waking up. Initially, nobody knew what the heck was going on with him, why it happened. One of our house staff sent a blood test and it actually showed a heart attack in a 35-year-old kid. And his dad, who had a heart attack, was there. And so we took him downstairs and we found a blockage. I'm going to show a picture of it. And that blockage, we all looked in the room and just went, we had to take a step, and we fixed it. And he just got back from Spain. So it's a great story. We got him off the ventilator.
But he had no idea that he had risk factors or that he had anything wrong with him.
No.
Wow, that's scary.
Well, as we'll encourage you to look at, you have to know your numbers. We've said that in our prior video. You have to take action. All of those things. I mean, you don't know to do that, but that's what I'm going to encourage you to do. My initial 27 years used to always be get to it before it gets to you. That was my motto. I did it on various other platforms, if you will. Now, it's get to work.
I have a question for you. I asked you this the other day when we were out on a walk. For women, we're really encouraged by the age, I think it's 40, and now I'm going to get it wrong, but to get a mammogram.
Yeah.
By age 40 or before, and it could be earlier. So, but for men, you don't have those recommendations.
No.
Right? I asked you, the American Heart Association doesn't have a recommendation that by the time you're 30, 40, whatever the number is, to get baseline cardiac testing. But more and more, you come home and say to me, I had this young kid today. This kid was in his 40s. This kid was in their 30s, and so. I know there's a whole host of things. There's lifestyle, there's, components that affect that. But what would be your recommendation for people who know your numbers, right?
Well, you have to ask the first question, am I at risk?
But how?
Some people don't know. You have to go to the right people, ask the right question, get the right answer, and together you do something about it. Yeah. You have to know. Cy Sims, I call him the great poet and educator, and for those that are old enough to understand that, he was a clothing manufacturer, a clothing salesman, and but he had a great quote that I still say today: an educated consumer is the best customer. So I encourage my last patient on Friday. He just loves bringing me articles, and we sit and talk. Thankfully, he was my last patient, and we talk about bad cholesterol, and we talk about other treatments other than statins, and he just likes anything controversial, and we go at it. But I encourage that. So that's what you want to find. You want to be able to talk to your doctor and ask them the right questions and get the right answers, and then be proactive. But we'll talk about that as we go along. So this leads us into the fact that standard testing doesn't help. I've given a lecture before called "The 5 Things You Think You Know About Life and Death, But We're Dead Wrong." Right. And the two apply here are very simple. Stress tests. Stress tests really only detect severe blockages that affect blood flow during stress. So that's a big thing. Again, this plaque that we're talking about, the heart attack that you never see happen, that's not what a stress test can tell us, okay? Likewise, an EKG, that's also one of my top 5. The EKG, it represents a snapshot, a fixed snapshot in time, so that it's going to miss silent decreased blood flow, and really is only important, if you will, during an acute event. Somebody has angina and chest pain, and we might see a change. Somebody had some chest pain the day before, a month before. Right. I have a case of a patient that had mild blockages 20 years prior, and everything was great. He exercised, he dieted, he ate right. And then I saw him. He became a snowbird, going back and forth from New Jersey to Florida. And he came in before he left, and I looked at his EKG, which is routine for 20 years, and it looked like massive heart attack. And I looked at him and I said, "Are you okay?" And he went, "Yeah." And I went, "You haven't had any chest pain?" "No." "Shortness of breath?" "No." "Tired?" "No." And I went, "Nothing in the past 6 months, nothing's happened." And he goes, "Well, a couple months ago I was gardening outside and I started getting pain in my shoulder." And I went, "Really?" And I said, "How long?" He goes, "I don't know, I just thought it was arthritis." Hospital, 90% blockage, 99% blockage. Fixed it. P.S. EKG completely normalized. He goes back and forth to Florida. He's doing great. But this is the kind of thing. This is the heart attack you never see happen. We say it over and over again. So what helps in this case? And I will say this many, many times. You will hear me say this, something called a coronary artery calcium score. It's kind of a misnomer, because it's about plaque that gets hard and calcified, so it turns white like milk and yogurt and bone. But it really could be a plaque score or a blockage score. I like telling my patients, think of it that way. They identify high-risk blockages, but not what you think. It doesn't necessarily mean that it's an 80% blockage. So by 2015, and they came out in 2004, they found that these calcium scores predicted events better than traditional risk factors, blood pressure and smoking and diabetes, family history, and the risk scores. We have these little apps now that you can enter in, and doctors can enter in a risk score and predict. The calcium scores actually did better at predicting that.
For men and women?
For men and women. And women, by the way, better.
And what about age-wise? So is there a particular age where that no longer becomes as relevant?
Well, yeah. So we often say, and we'll talk about it in our last section, greater than 40 in general. And there was a recent study that showed really less than 40 for most.
40 years old?
Years old. Oh. Thank you. Benefit. There's less benefit or less predictability, if you will. And really about 75. As we all get older, we all get plaque in our arteries. So again, we have an 85-year-old lady that was sent for the scan, and her score, 0 is normal, over 100, we start taking action, both lifestyle and medications. Greater than 400, we start saying, hey, you're much more higher risk. Those are our numbers that traditionally we've used over the past 21 years. But so her number was 1,600, and she was having some pain, but it was heartburn, and it sounded like heartburn. And her EKG was normal, but a lot of women can have abnormal EKGs. As I said, it can just, where's your EKG? The leads are all over your left breast. So she was recommended a catheterization. It didn't sound great, and they came to me as a second opinion, and I was like, well, but you've already been told you have this. The scan was already done. You're having pain. I don't think you have a blockage.
So it wasn't really relevant at that
But
age.
I couldn't say, no, you shouldn't have this. If you want to have the other doctor do it, she asked me to do it. And I said, okay, I don't think you'll have anything. And she said, I like your optimism. At the day of the procedure, I said, I'll see you in 5 minutes. And she said, from your mouth to God's ears. And sure enough, normal. And I said, I walked up to her at the end and I said, go live your life. Yeah. And how many years ago? I think she's almost 90. Okay? So, and she's lived her life. And it's a great thing. So it's a good story from that end. All right, what about bad cholesterol or cholesterol in general? Just LDL cholesterol is outdated. You have to look at other factors associated with the bad cholesterol and other markers outside of the cholesterol. Particles, you'll hear me say this a lot, really make up more of an accurate way to assess bad cholesterol. There's a marker called ApoB, which is indirect and probably covered by most of the insurances more, and a more direct way to do it just called LDLP or particles, and it's the total amount of particles. Think of mud versus sand, okay? Sand is easy to filter and mud sticks. And that's way. So you can say unhealthy versus healthy, sticky versus not sticky, but it helps us guide therapies, lifestyle and medication therapies. Inflammation, we talk about it all the time. The traditional marker is called C-reactive protein or CRP. It's somewhat outdated. There are markers that I will look at. Other than that, for the arteries, CRP is a general marker, what we call acute reactant marker for anything. You get it for your autoimmune disease, and it was 0 when we checked it how many years ago, and now it's, well, actually yours is always normal despite that fact.
But I do have a lot of patients in my practice women who are in menopause or postmenopausal, their cholesterol all of a sudden has gone up and they've had a lot of factors, and all of a sudden they come in and they have, oh my, what does this mean? My CRP.
Yeah, because people read it, and by the way, if you look on your narrative on your lab, it'll sit there and say, well, less than 1 low risk, 1 to 3 moderate risk, and greater than 3 or 3 to 10 high risk for a cardiac event, an acute event like a stroke or a heart attack within, at least the old data was within 10 years. But there's a lot has come out about that because, again, a case of a young kid, I did it, his father had heart disease, so I screened him, and his C-reactive, again, less than 1 being normal, his was 33, and I looked at him, I went, you okay? And he went, yeah, I'm fine. I was like, nothing wrong, no infection, no trauma, no arthritis, no recent surgeries, because all of these things can increase that marker. And he went, no. And I went, all right, we'll check it again in a month. We're doing other testing in the meantime. And it came back and it was 1. And I looked at him, and he went, he put his head down like they do when they're afraid about testing. You're gonna be mad at me. He goes, I forgot to tell you, I had a gum infection and I was on an antibiotic. And of course, so he got the treated infection and it went down to normal. So you have to be careful and take that with a grain of salt. My patients get so worried when they see that number, and they we have a portal and they look at it ahead of time and they just think, well, it can be affected Chicken Little, the sky is falling.
Too much alcohol, right? It can be affected by weight. It can be affected by diet. I mean, there's a lot of things that can affect it. So you have to go to the source. You
have to go to the source and an educated source from that standpoint.
All right. Not TikTok. Or any social media platform,
there are good people that are on each platform, and
absolutely, but
and
there's
then
a lot
there's
of misinformation. It can be scary, right?
So let's get to work. All right.
Yeah.
Let's get Number 1, we have 4 things to help you take control of this and prevent the preventable, because that's my goal in life. You have yours in terms of how you practice. Number 1, change your diet.
Yes. Anti-inflammatory diet. And cracking the food code is my cheat sheet to anti-inflammatory diet and gut health. Those are really 2 prominent.
Helped me.
2 factors. It did. You lost, tell them, 40 something pounds, right? I also have an online program, it's Phil's 30-day reboot, and it really is like cleaning the slate, teaching you how to get all the inflammation out of your body, and then what to put in, right? It's fine, we know what to take out, but then how do we refuel it and keep that sustainable? So anti-inflammatory diet. And then, we talked a little about oxidative stress, and just for like a quick fun 10 things that you can add in your diet today to walk away with.
That's great.
Top 10 antioxidant foods. Blueberries, my favorite, I eat them every morning. Green leafy greens, broccoli and Brussels, turmeric, or some people take a curcumin supplement or fresh turmeric. If you are taking a supplement, it's really important to also take it with black pepper, right? Bioprene helps absorption. Green tea and matcha, another favorite of mine. Pomegranate, fatty fish like salmon, mackerel, sardines. Am I forgetting any? I don't know.
Beets.
Those fatty fish.
Beets.
Well, beets are on there, but not on my top 10. Dark chocolate. So I'm not always the bearer of bad news, 70% or more. Nuts and seeds.
She taught me this on our second date.
What?
Dark chocolate? Yeah. I looked at her and I went, you should have been a doctor. You should have went to medical school.
I don't really think saying dark chocolate.
No, you quoted articles to me on our second date.
Yeah, we're kind of nerdy if you haven't figured that out. Chia seeds and flax seeds. And one of my favorite things that you really can help, it's like soothing those arteries on fire, is a really, really good, healthy olive oil. And you can find all the details that in my book as well, but quality does matter in any food that you're eating. It is incredibly important that the quality of the food is your primary concern.
Well, ultra processed foods.
And we're going to talk about ultra processed food.
Well, no, I mean right now, that is a big deal.
Yeah.
Ultra processed foods,
stress and inflammation,
it attacks your brain, your heart, and your life.
Yeah.
We're big on that because at the end result is a heart attack.
Yeah, it is.
So that's for a long discussion. So how about number 2 is we talked about it a little bit already. Know your risk.
Yeah.
You have to know your risk. So I talked about calcium scores already, coronary calcium scores. So especially if you have risk factors, especially if you have family, if you're between that 40 and 70, and a lot of times we'll bleed it over to the mid 70s, but if you have a family history and you have high blood pressure, you have pre-diabetes, diabetes, you have obesity.
Well, some people don't know because they don't get their blood.
They don't know, but I'm saying you have big risk factors.
Yeah, absolutely.
And you have a family history.
Yeah.
And it's not just the old way of family history is, if your dad is less than 55 and your mom is less than 65. I like to look at it as like if there's multiple generations, or if you have even one relative, it's still reasonable.
Well, I had a patient recently, and we do a health history questionnaire, and it says, tell me about your mother's health and your father's health. And I'll say, do you have any heart disease? And they'll go, no. And then conversation, right throughout the conversation. My dad died at 55 of a heart attack. My uncle dropped dead. My brother had a heart attack. I'm like, you have heart history in your family. But people aren't even sure that's what that means, right? So knowing your numbers.
So it's a 2-pronged approach. And number 1, you can get to see if you're high risk plaque, and number 2, you get the right blood work, you get the right labs. So it's not just a bad cholesterol and a triglyceride and a good and a total and ratios. I used to do a lecture called "I don't care about your total cholesterol, and neither should you."
Let's talk about the metabolic.
Well, that's it. But that's it. So, but these particle markers, ApoB and LDL particles, something called lipoprotein(a), and that's a real big one for me. I've been treating it now for 23 years. Lipoprotein(a) or Lp(a) is like the evil mutant twin brother of bad cholesterol. And it runs in families. 1 out of every 5 people will have this if you have a family history. Doesn't mean you'll have a heart attack. Doesn't mean you'll have heart disease. It just means that you should know about it. And then there's lots of both lifestyle measures and certain, and medications. It's not the way it used to be 23 years ago when we started, My God, what we used to give back then, niacin and estrogen and mandatory statins and all of these things. We just don't do those things. Inflammation, inflammatory markers, and then just as you said, get an office eval, go to a dietitian, cardiology. We don't do it as much, but get evaluated for insulin resistance.
Yeah, so you want to check your hemoglobin A1C. That is a snapshot of how much sugar is in your blood over a 3-month period of time. You want to look at your glucose levels, your insulin levels. You said HDL and triglycerides. Know your blood pressures. Do you have hypertension? And also do your waist to hip ratio, right? For years, people just looked at BMI. It's not as inclusive.
And I still do, and I know I shouldn't, but we don't do the waist to hip. That's the problem.
Waist to hip is really a better indicator because it tells us about fat distribution in the body, right? Are we an apple or are we a pear? And is that fat distributed in a healthy manner, or is it more where that fat becomes what we call metabolically active? And that's where we run into a lot of problems. So these are a few key indicators when you go to get your blood work. Ask your physician, ask your healthcare provider, can you please check these markers for me?
Absolutely. Number 3, again, we touched on it, but you have to be an advocate for your own prevention. You don't need a symptom to get a test. You just need knowledge. And if you go to somebody and says, well, you don't need that, you don't need that, you can answer, and here's a good quote that you can take home. Heart attacks come from the inside out. If you don't see the wall, you miss the threat. So I like that one from that standpoint, that just allows you to be an advocate for your own prevention. And then lastly, I call it the 3 Ps. Know the signs of a heart attack before it happens. Now, women tend to get a warning way more months than men do. They can up to 6 months, and men can have an acute event.
You mean like a symptom that they may
well, just the women tend to get warnings before they actually have that acute heart attack, the old heart attack you never see coming. But women tend to sometimes get a prodrome. Not all the time. Obviously, no one's created equal. We know that. But I call it the 3 Ps. If something's getting more profound, if something's getting more persistent, if something's getting more prolonged, that's sign to get it checked. Yeah. Pick up the phone. Should I be worried about it? We did have a patient. He didn't pick up the phone. He kind of went through our portal, and he had prior heart disease, and apparently his shoulders were getting achy. And he had even said something like, should I be worried about this? But nobody really saw that, okay? So, he ended up having bypass surgery, okay? So, I'd like to say, hey, look, that's a sign that something got missed, and we don't want to miss that. None of us want to miss that. I don't like it.
It's kind of like when you were a kid, right? No question is a dumb question. Just ask if you're not sure. I think one of the things really important too is talk about signs of inflammation, right? Because they're not always so blaring in your face that, oh my God, it's inflammation. Because it can show up in a lot of ways, like brain fog, fatigue, GI distress, right? You can have heartburn or a lot of acid reflux, achy joints, which, unexplained weight gain. A lot of times people don't understand that the weight gain has come from inflammation in the body, frequent infections, skin problems, rashes, sleep disturbances. Not that you can't sleep one night, but if you're having a lot of reoccurring sleep disturbances, mood swings, anxiety or depression, and don't ask your husband because he's going to say you have them, and cravings for sugar, because that's a really big indicator that there's a lot of inflammation in your body. And when we talk about inflammation in terms of your gut microbiome, we're going to really dive into that as well.
Yeah, fatigue is a biggie. Yeah. Tiredness, but I always say, look, we all get tired from stress, and we all get tired from work, and we all get tired from this and that. But if it's all of a sudden new,
or you don't get less tired
I say, well, are you taking naps all of a sudden?
Right.
That's a big sign. We have a mutual friend whose parent I took care of, and the EKG was normal, and the stress test was normal, but a calcium score, again, talking about that because you hear it a lot, was 1,500 or 1,600. And they wanted to keep on doing tests, and so I was a second opinion, and I was like, well, at this point, I think we need to go look. And there was a 99% blockage and a 90% blockage. Fixed, doing well.
Yeah.
And tiredness was the only thing that he had.
So if you're not sure, ask.
So you're not sure, ask from that standpoint. So in closing, just because the plumbing flows doesn't mean the foundation isn't cracked. I think that's
it's
a
a great
great way
analogy, yeah.
just to kind of take that home. We encourage you to, as I said, be a patient advocate.
For yourself.
For yourself. Get to it before it gets to you. And again, prevent.
Know your numbers.
Yeah, because
Know your numbers.
you can prevent the preventable from that standpoint. So we encourage you to like this episode and share with your friends, please, because this one you can certainly
Save a life.
pay it forward from that standpoint. And subscribe to our channel and other YouTube sites under Phil and Dr. Scott Unfiltered, so that you can be notified of future episodes to come.
And go to philknowsfood.com. On my website, there are a lot of free resources and guides that are nutrition, oriented to help you with all the things we talked about today. So there's a lot of free resources there for you as well.
All right.
Yep.
We'll see you soon.
Get to work. Hi, I'm Philippa Bebbington, registered dietitian and integrative wellness specialist, and I am the creator of Phil Knows Food and the author of Cracking the Food Code.
Hi, I'm Dr. Scott. I've spent 30 years in the cardiac cath lab, and I am sick and tired of seeing preventable diseases not prevented.